Welcome to the Moulding Health Show. Our goal is to leverage the wisdom and experience of healthcare practitioners to set you on a path of self-discovery and healing. These insights, coupled with a multidisciplinary approach to each area of interest, should provide an invaluable resource to everyone looking for a better approach to health. In this episode of the show, we speak to Ruwaida Moola about antenatal care from a midwife perspective. Ruwaida Moola, welcome to the show. So we're really glad to have you on board. Thanks very much for doing this.
Thank you so much for having me. It's really a pleasure and honor to be here, Oliver.
Yeah, the pleasure is always ours. And today we're talking about antenatal care from a midwife perspective. And, in the brief, we also talked about the whole psychological aspects around it. And I'm really interested to get through, this topic with you. We've got two little kids well, they're not little anymore, but two kids of our own. And it's interesting, to compare that as well. But firstly, just to kick it off, tell us, what is antenatal care? And then we can go from there.
So antenatal care might differ a bit from the obstetrician and the midwives. With us, the moms come through and we see them throughout the pregnancy. So some moms want to know, when can they come across? And I generally say as soon as you want to, because we can go through dietary requirements. We can go through your care, cover a lot of the psychological aspects so you're reassured throughout. So it's emotional care that we provide. It's the emotional support, but then the physical aspects as well. So ensuring that your overall health is checked, your blood pressure, your blood results, antenatal screening is done. We're able to refer the moms for the checkups to the obstetricians for their backup care as well, because there's certain things that we don't do. For example, the 12-week scan, the 20-week scan that the fetal anomaly specialist does. So if the moms comes and sees us quite early, we're able to refer and we're able to get all of those, blood tests and whatever's needed and put them into place so that we don't have any problems or complications towards the end. So it's monthly checkups, and we work according to the World Health Organization standards, where it's every month until the 28 weeks, and then towards 28 and 37 weeks, it's every fortnight. And then from 37 weeks, I'm sure you as well, Oliver,
yeah. Have your bags packed, essentially.
Have your bags packed. So it's a full range of care and treatment, monitoring not only the mom, but as well as the baby, ensuring fetal development and growth throughout. And then towards the end of the pregnancy, we discuss a lot of dietary requirements, and we also discuss the preparation that you need psychologically and physically. My quote is generally, I say that it's like preparing for a comrade. You have to get ready, mind and body, so that you're ready for the labor day.
No, that's amazing. I can probably go down the comrades route. Not that I'm a runner, but as what people have told me. But they always say like between Jan and May, you have to get like 1,000 Ks in, and that's like your hard work, just to prepare for the day. But yeah, I'm sure pregnancy is way more difficult. I'm saying this, from a non-woman perspective, but it's definitely sure. I watched my wife, and it was difficult. Hey, both the pregnancies. She had morning sickness for most of the pregnancy, so she could hardly keep anything down, and stuff like that. But it was pretty hectic. I do want to get this point clear though, because what's amazing about doing the show was lots of the things that I probably had in the background, kind of comes to the foreground now when I think about it. So even the whole discussion about a midwife, and I'll be honest, like when Ingrid was going through the pregnancy, we didn't once consider it, and I just want to make this point clear is, what is that difference? Because we went to a gynecologist, and I don't know if that's completely different from the obstetrician. But at what point would a woman or the couple consider, either going through those different routes? Can you take us through that?
So a lot of people associate midwives with the women in the community that used to go out and just birth you without any knowledge or experience, but based on just their experience, really. So that has changed, and that doesn't really exist anymore. So with midwives, we study, we train in and specialize in normal births. And that's what we are expertise at. And your obstetrician, we generally use when there's a high-risk pregnancy. So the mom now develops high blood pressure or diabetes, she now needs medication, or a cesarean section, or fetal checks, which is intricate, and the fetal assessments. That is the obstetrician or the gynecologist, and that's what they focus on. We specialize in normal birth as midwives. So when our moms want a natural birth with minimal intervention, and they fit in the low risk criteria, which is the low risk is no high blood, no low blood. South African Nursing Council has a criteria that we focus on, and we work according to those regulations. And if the mom fits in that criteria, then we birth them as natural as possible with minimal intervention. So hardly epidurals, yes, because we work on a lot of natural pain relief methods. And we do the birth, be it in water, out of water. We get a lot of requests, so in water births or not. We able to, many moms want to know, are you able to stitch me if I tear? So yes, we can do that. We stitch you. We are able to perform episiotomies, which is a cut. And we're able to do vacuum extractions if it's within the, the norm of it. Obviously, if there's anything that differs from the norm, where we need intervention, where we need a gynecologist to step in, all moms see a backup gynae, and they only step in if need be. And we don't only call them when there's a last minute emergency. We call them when we already detect that there's going to be a potential outcome that they'll be needed for.
Okay, that's actually interesting. So I do want to, I had it on my notes to actually ask about the water birth, because that, it's almost like, like you either going to choose that or you don't. And I think so some women definitely have, a preference towards that. But my question is, so in those kind of centers, is it like in a medical center though? Because how is the gynae on call? Because I think that's the one issue is like, like if they're not on call and, something goes wrong. But I suppose with pregnancies as well, the labor could take longer. So maybe there's still time to get someone in. Are those does the delivery normally happen like in a medical center or like a hospital or something like that?
I love that question. I love it. So I might just go a bit longer on this one.
Sure.
So all our moms must see a gynecologist at 28 weeks and 36 weeks. That specific gynecologist then has the history of the client and has seen the client and has declared the client as a low-risk client. And is okay that the mom proceeds with a normal birth. So as soon as that happens, that's the gynae that we call out in the event that we need them. So we generally birth in maternity clinics where we have midwives focused. So Genesis Clinic is one of the clinics that it's midwifery based. It's for midwives to birth, not the gynaes. The gynaes only come out to do a cesarean section or assisting. The same with the general hospitals. There's staff midwives that are monitoring gynae clients. And then, when the moms go in, it's the staff midwife that will put the mom on the monitor baby's heartbeat, do the initial assessment, and then phone the gynae and say, we have this client, and keep the gynae updated. The gynae then comes out, does their assessment, and then leaves again. The midwife takes over, comes back for the birth. So it's a bit of a change. With our clients, we update the gynae, but the gynae doesn't come in to do that assessment because they'll only come out if need be. If that specific gynecologist or obstetrician is on leave, they have their backup that will step in. So these are all in medical or maternity clinics that it's taking place. I recently opened Birth on Fifth. It's a maternity home unit. So if you look at the bigger public hospitals, for example, Rahima Musa and Helen Joseph and all of those are tertiary hospitals. They all have theatre on site. And then you get the little clinics, it's called the MOUs or the level 1 clinics. That's your Crosby clinic or your Discoverers clinic, or these little MOUs where they birth in the clinic. The clients will go to the public sector, attend all the classes, attend all the care, and then when in labor, go through and have a normal birth. But if they need it, they then transferred out to the bigger hospitals like Chris Hani or Rahima Musa or the surrounding level 3 clinics. So I've adopted the same concept with the maternity home to give moms the opportunity to experience private care, but also based on a level 1 kind of a unit. So this is not, it's still a medical facility, but it doesn't have a theatre on site. And that's the difference. So the level 1 or the MOUs might not have a theatre on site, and then you get the bigger clinics, which has a theatre on site for emergency cesarean sections.
Okay. Thanks for clarifying that. And the only reason I asked this question is, when we were, my daughter now, she's, turning 14, but when she was a lot younger, we used to always do this, there would be an anesthetist in the chair, at the dentist surgery. And someone asked us, it seemed like an innocuous question at that time, and said, yeah, but what happens if something goes wrong? And it always stuck to me, at that stage, because if something did go wrong, there wasn't any medical staff around. And after they asked that, I was like, wow, okay, maybe we shouldn't be doing this, and it's, I'm not saying it's unsafe. I'm just saying it seems to be a common practice maybe in Johannesburg, but yeah, we stopped doing that though, just because of if something goes wrong, what happens? How do we get her to to the healthcare center or hospital? And a friend of mine, his wife was actually a midwife, and they're in Australia now, but they actually, I think they sold their practice to Genesis in the early days, but they had a partnership with maybe 3 or 4, midwives or colleagues, and her name was Tamsin, or is Tamsin, but she said, and it was always amazing because we would go out for dinner or go to movies, sometimes, and I would ask her, so because her clients would call her at all hours of the night, and she would always be all friendly and all of that stuff. And I'm like, how do you do that? do you have the same? Are you permanently on call, with clients?
Yes, so I know Tamsin quite well.
Okay.
We've worked together
Lives
for
in
quite
England,
some
yeah.
time. Yes.
Yeah.
Yes, exactly the same concept. We on call 24/7. And our clients know, our clients have a better scheduling of than we have. They know when I'm going on leave because my leave is prepared 9 months in advance. So they know that I'm unavailable during that time, or I'll have a backup or on-call midwife that will take over clients, because it is the client's preference. If they know that I'm away in December and they don't want to see my backup, then they'll see another midwife from the get-go, just so that they are prepared as well, not to see a new face at the time of birth. So my leave is generally prepared a year in advance. It's set. When clients do a general inquiry about my services, they have my leave dates as well that is sent out to them, because labor occurs in the middle of the night when your body is relaxed and you're producing oxytocin. And yes, we have to be on call all the time.
Okay. And you don't find that difficult? This is more just a personal question. I know I would struggle with that. I suppose I'm a lot better now that we have kids, because I used to not be a morning person, but now, I am, by virtue of just the fact that you have to get up for school. But yeah, you don't struggle with that at all?
No, not at all. I think that when I chose to do well with, I think from 19 years old, I knew this is what I want to go into. And so you prepare your mind and you're so ready for it that it's as good as me waking up. It's the same as going out for a birth. It's just all part of it. So, and the family is the same. My husband and he was with me before I even started midwifery and when I was in my training. So we adjusted to that. The kids, that's exactly that's how they know things are, in the house. So it's the norm with us. And if it's the norm, it actually works in your favor.
Okay. So I was asking a swimming coach recently, that teaches the kids, and because she works crazy hours, like as well, but fortunately not like at night like you do. But and I asked her, like, how do you cope with that? And she said, very understanding and accommodating husband, and I'm sure it must be the same for you as well, because I mean, you probably schedules, you can't keep to, like too well, depending on when you're going to get the call and stuff like that. But yeah, amazing stuff. I like to see that calling stuff coming in as well. Eh? I mean, you knew that from like an early age, and I think that's probably what clients see with that as well. That's definitely something I got from Tamsin. But you had a few partners, and so do you have like a similar setup so that you can rely on someone else if you're not there?
I must say the midwifery fraternity is a very close family. We always rely on each other because, and that's one of the things clients ask me, what will happen if you have two births at the same time? So yes, I can always call on my colleague. We work hand in hand with each other. We bounce ideas off. We fill in for each other. And that it's the family unit in the midwifery is amazing because we have to have that and we have to have that support as well amongst ourselves. So I don't have a partner per se, but I have a lot of colleagues that I call on to if need be.
Okay, that's amazing. So the other term that comes up a lot is prenatal. So can you just tell us, I mean, the difference? I mean, again, from a layperson point of view, just so that we don't get these terms like mixed up. But what is the difference between those two?
So your prenatal is before the birth, or with antenatal or prenatal, it's during the pregnancy. And that's everything that's done during your pregnancy. So prenatal classes or antenatal classes. So that's the classes that you go for during your pregnancy. And then you get postnatal, which is your afterbirth immediately. And then you get postpartum, which could be a bit longer than your 6 weeks. So your pre is the before, and then your post is after the birth.
Okay, cool. So it's very close then. I mean, like, in terms of prenatal and antenatal, and in terms of that, the postnatal is obviously different. And again, like I try with the show as well to tie it back to some of our experiences. But the one thing I noticed, and I don't know if this is different with from a midwife perspective, but I found that it was almost, like the gynecologist was there all the way until the birth, and then it was the pediatrician's job, and it was like, like done and off. Like, is that how it works with midwives as well, or is it? I mean, does it stay on after that? Because I mean, there's checkups. I mean, I mean, it seems very like black and white when I say that, but I mean, there was a checkup with the gynecologist after that, but it just seemed like a very cold. I don't know. It just didn't feel, it just didn't feel good. It just felt like it was just like a handover to the pediatrician. But with the midwives, do they stay through that whole process and even post that? Because I think that's a really important, aspects to it.
Yes. So with midwives, we when the mom goes into labor, they give us a call, and we meet them at the hospital or the clinic that they are going to. So the first phase or the second phase that they see, we're there from the very start. We do our own monitoring with our clients, so we don't let anyone give us feedback on the client's updates or progress, which makes it easier, which the gynaes unfortunately don't have that because they're unable to be with one client all the time. So they're relying on a midwife's assessment to make their decision. Whereas with us, we're doing our own assessment, which is quite easy when you need to make that call because you've been with the client throughout. And we there at the birth, so we're able to birth the client, do the immediate skin-to-skin contact with the client. For example, Genesis has a pediatrician there on site during the day, and if we need the pediatrician at night, we just give them a call. They're not far at all. So the pediatrician will come out to do the assessment while we are there or the next day. We do the skin-to-skin with the mom because we are so big on the immediate bonding or the first golden hour after birth. We are in love with the golden hour, so we want to ensure that the bonding between the moms and the dads take place. We do skin-to-skin with the mom, we do skin-to-skin with the dads, we initiate breastfeeding as well within that time, and we don't leave our clients. We generally assist the moms to the bath or shower afterwards, so they're not alone when that happens. Tuck them into bed and then leave them. And the next day come back and see them. And we all see our clients 3 days after so that we're able to ensure that our babies have gained weight, to ensure that it's not the pediatrician's hand over, we don't hand over to them. We do the checks on the baby, make sure that the baby is not jaundiced. And if the baby is jaundiced, then call out the pediatrician. Or we even do the phototherapy lights ourselves and keep the pediatrician updated on that. And then we see our moms again at 6 weeks. We actually see our moms at 3 days, and then a week later, and then 6 weeks, and a year later. So it's a long-standing relationship that we have.
Yeah, no, that's actually really beautiful, hey. I mean, and the way the way I think about it, it seems like a lot more warmer. Like maybe that's what I was talking about just now. It's like it's definitely a lot more warmer. I mean, like the pediatricians were amazing. I mean, we only used one for both the children, but they were amazing. It was amazing seeing them work, and at first, like when the baby is born and what they have to do and stuff like that. But I mean, they definitely do all of their checks and balances. But I think the first time I probably thought, maybe there's issues is like where we had a social worker on. Her name is Sally Baker, and she was talking about birth trauma and like how, like women really, I mean, like it's quite a revelation, like especially the first birth, like how difficult this stuff is. And I think, when Chaz spoke to me about having you on the show, we spoke about like the psychological aspects of it as well. And I go back to that warmer, idea that I just said now, is that it definitely seems like a lot more of like a support structure around, the woman that's going through. Is that how your clients experience it as well?
That's exactly how they experience it, because they and that's why they come, I suppose, to midwives. They want that support throughout. They want somebody to walk with them, somebody to empathize with them, and at the same time, with empathy, also to be knowledgeable about what's happening medically. So they get the package deal because we also do psychiatry in our training, so we're able to manage that and be able to look at the psychological aspects of our clients. I do have clients that sometimes will still go back and say, sure, this birth was traumatic, and associate the birth trauma with the pain that they've experienced. And, initially I used to try and go over and over my head, what was so traumatic? Because for me, it was the most amazing water birth, and she didn't tear and she got to breastfeed. But birth trauma is so subjective. It's not objective. It's what the mom feels at that time. So the pain that is associated with the labor can be quite traumatic because it is very intense. And even though we are there, and a lot of the moms might need Sally as well, we refer to her to debrief about their birth so that they can unpack that trauma and put it into perspective and work through it so they don't have that build up before their next labor that they're going to experience.
Yeah, and it's the smaller things, hey, that you almost like don't think about, because I would have never thought that. And both the pregnancies, for my wife were quite. Well, maybe she would disagree, but I wouldn't say traumatic, but definitely it was difficult. Like I remember for our boy, for Tristan, it's interesting that you mentioned backups. So the gynecologist had a backup, but my wife just didn't trust whose backup was or anything. So the doctor was going to leave, I think on the Thursday or something, for holiday, but he was gone for a month or something, and Tristan was born on the Tuesday. Like almost like in my wife's mind, she was like, "No, I'm not leaving this up to chance." Like he's coming a bit earlier. But yeah, it was interesting. But yeah, so the whole trauma aspect, as you said, what I was trying to mention with that is that I think it's dependent on per person, but it's also, I think that's the thing I'm learning with these episodes. You almost have to always take the other person's position or feelings and approach into consideration. It's not about, like what you think it is, I suppose. And I'm sure with many patients, you probably see something like that.
Absolutely, I 100% agree on that. So everyone has a completely different outcome, and they also have a different story to tell, and different ways that they view and feel things based on what's happening with them as well, what happened with during their pregnancy and how they felt from the get-go. And it's our job and it's our duty to make them feel comfortable and to try and help them get through it as best as possible with a safe, healthy outcome. And it's not only a safe baby, safe mommy, but also psychologically that they are able to look back at it and be empowered and be happy that they've experienced that birth.
Yeah, agreed. I remember, like when the doctor was, when with the first pregnancy, like the doctor said, if it was up to men, they probably won't ever have the second child. But it's almost like, like women seem to forget that, and it's a joy, after you reflect back, it's like, wow, that was amazing. But I think in that moment, it must be quite difficult. But like, probably men would just be way more, like, there's no way we're doing that again, kind of.
Yeah.
But coming back to, sorry.
The birth I had last night, the dad was so empathetic, and he looked back and he said, "Sure, if this was me, I would have been dead." Wow. And I agree.
No, yeah. I mean, all hats off, every amount of respect. I mean, like for that stuff. To the point where, I mean, like I think most people don't realize that even the pregnancy even changes the body. And like I know, like with my wife, it's like, she says now, like many years later, but like this and this happened, and only sometimes she only figures it out like later, like I think she got, yeah, like just different like chemistry and stuff like that. I think it was like a thyroid issue as well, that she picked up or something, but definitely changes the body. I think that's a key thing, and I think for women to go through that is actually pretty amazing. Yeah. In terms of antenatal, so when should it start? I mean, like, so does it start? And I suppose what I want to round this up to as well is that if anyone's listening to this, and we already painted the picture a little bit in terms of where midwife would come in and where gynecologist probably would come in, but when should that process start, and when should they almost like try to make up their mind, actually, am I going to go down this route or that route, and how would they find more information around that stuff?
So they would do their pregnancy test and find out that they're pregnant, and a lot of the moms would, I must say, it really is dependent, and I've noted that this in South Africa that is dependent on their financial status. So if they are on medical aid and they're able to go and see a gynecologist, then the moms would then see a gynecologist from the get-go. So to go for their first scan, to get to see the fetal heart, which might be at 6 weeks, to ensure that there's a single pregnancy or a twin pregnancy, and that's very early in the pregnancy. Then there's moms that might not be on medical aid or unsure about which route they're going to go, and they might see a GP that also does prenatal scans and see them until they know which way they're going to proceed. A lot of our moms only figure out that they want to go the midwifery route after about 20 weeks, I must say.
Okay.
So my recommendation is always see the gynecologist for the 12-week and the 20-week assessment. Because at the 12-week assessment, the gynae is able to do the first trimester screening, and the first trimester looks at neural tube defects, Down syndrome, and genetic abnormalities. So there's a scan that's done in conjunction with blood test. And then at 20 weeks, they see the fetal specialist or the obstetrician again, where they look at the internal structures, looking at the baby's brain development, the little heart, how the heart is developing, is all the organs in place, how the kidneys are functioning. Does the baby have 5 little fingers and toes, looking at the lip? So the developmental structure, they look at 20 weeks. But from the get-go, we do blood tests to determine if the pregnancy is progressing well, the blood grouping, her iron levels. So all those tests can be done with the GP as well in the early stages of the pregnancy. Now, there's a lot of moms that might just do the pregnancy and I'll go for my checkup when I'm 3 months. And not realizing that the initial stages, that first 12 weeks, is when your baby is starting to develop that little spine and the skin that's behind the spine starts closing, and the moms need folic acid in order, or additional folic acid that also helps with that. And if they don't take folic acid, or there's an increase in alcohol or drugs at that stage, that does affect the development of the baby. So my advice to all moms out there is please have your assessment as early as possible so that we're able to guide you and put you on the correct vitamins and supplements for that. And if there's anything short that you need based on your blood test and our assessment, we're able to guide you with that as well. So
Okay.
does that give you the answer on when they should start that?
No, yeah, that was very comprehensive. But as you talking about that, I was thinking about the whole nutrition aspect and care during pregnancy is probably a really big topic as well. It's like what should you take, and I mentioned, like with my wife, I mean, she couldn't keep much down. And eventually, the gynecologist just said, try the best you can. She had reflux as well, so it was just like crazy. So, but I know, like, best case scenario, you want to try to get the nutrition, perfect. And obviously, things like smoking and drugs and stuff like that should be a no-no, right? I know you mentioned alcohol just now. I would have thought that's a no-no as well. But okay.
So yes, smoking, drugs, so I've noticed that also since cannabis has been legalized, there are an increased amount of that in the early stages of the pregnancy, which we're trying to stop. The younger generation, they do use it and not think about it passing on to baby. That's no drugs, no smoking, no alcohol. Because we have seen effects once our baby is born with moms that have been using this in pregnancy. And if there's anything that I can tell the moms is that it's so difficult for you to stop smoking or drinking or taking drugs. Imagine how difficult it is for the baby when the baby is born and they're used to this. The withdrawals that those babies experience, and it's extensive. It's very difficult. They need hospitalization. They might need even oxygen to get them through the first weeks. So everything that you do in the pregnancy does affect the outcome of the birth and the baby's well-being as well.
You might find this funny, but like so the one thing that Ingrid so before I say that, but I do notice, I mean, women are really good with this as well. I mean, like, I think for the large part, I mean, most women, do really well from what I've seen. There might be stories, but I did see, like some cases where I think there's a certain limit. I don't know if this is true or not, but like there's a certain limit to when you can smoke, and then it's actually okay. And then after that point, I don't know what that point is, but I saw someone smoke, like through the pregnancy, and then she stopped when she said, the gynecologist said that's a no, past that time frame. So maybe you can tell us if you know what that is. But with Ingrid, she during the pregnancy she had Coke, and both our kids, like, because that's one thing that she could keep down and stuff like that. And both our kids love like Coke. Hey? It's like, she like even now as a family, like there's always like Coke Light or Tab around, which is interesting. So yeah, it definitely passes. I don't know how, but yeah, we can't explain it, but definitely, for both the kids, they definitely do like that.
I suppose that, yes, I always notice that what the mom prayed for, the babies generally like that when they grow up. I know it's anecdotal, but I'm telling you, they need to do research on that, because there's definitely something that passes through there.
Yeah, and fruit as well. So Ingrid, like had a lot of fruit during the pregnancy, and both the kids, well, not both actually, Tristan doesn't, but Kiara does. Like she definitely likes fruit, which is interesting as well. In terms of, I know we covered it in bits and pieces, but if someone had to say, and they were going through the process, and they say, why would I choose antenatal care from a benefits point of view? Is there anything that springs to mind that you normally tell your patients?
Yes. So, and some moms might say, I have 3 kids before, so I don't need antenatal. And there's others that's the first time pregnancies that feel that they need more education, So the antenatal classes are educational classes. So it's not the antenatal care or antenatal assessments that you're getting with each consultation. Because on a consultation, we brief through we're unable to sit and talk for an hour and teach you certain things. So, and that's what the antenatal classes does. And it is so beneficial in terms of helping the mom with their anxiety levels. So when it comes to helping them cope better, because moms might not know how she's going to cope with breastfeeding. And, am I going to manage? Am I not going to manage? What do I do to prepare? How often I should feed? So there's all these questions that are bombarding her. She doesn't sleep at night because she might be focused on all of this. So your antenatal classes is there to assist you and advise with that. Teach you about breastfeeding, about bathing of baby. It addresses your dietary requirements. And then, like you said, with Ingrid, she had the nausea and vomiting and all of that in the initial stages of the pregnancy. So antenatal classes is good with that, because it could have maybe given you natural remedies that she could have used, reflexology, referral to reflexologists that might use the natural techniques to encounter or to assist with the ailments that you get in the pregnancy. So antenatal classes is excellent to reduce your anxiety that's experienced with all the pregnancy thoughts. Towards the end of the pregnancy, it assists with your preparation mentally to become focused. It's there to help eliminate the fear that's installed in you, especially when you hear about, for some reason, people love spreading fearful stories rather than good stories. So they'll tell you about the pain, or they'll tell you about how difficult it was. And that's the first thing that people say. I don't know why, but they do. And with antenatal classes, that could help you with acknowledging, okay, this is what you're going to experience. This is how you're going to encounter it. These are the coping mechanisms that you can use. So it deals a lot with the psychological coping mechanisms as well that you're going to be utilizing during your labor and your pregnancy. There's also antenatal classes which will cover hypnobirthing. So a lot of our moms try not to take anything medicated for pain relief. We use a lot of natural methods of pain relief. Hypnobirthing is one of the other, mind focus, where moms would learn how to mentally focus on something to help cope with their pain relief, to teach them the breathing techniques that they're going to be utilizing in labor. And I must say 90% of my clients don't take anything for pain relief, and not because I don't give it to them, because they never ever ask for it, because they're absolutely fine until the last, when the last intake is just about to come and they're like, okay, I can't, and then your baby's out.
Okay.
But it's a mental preparation, it's a physical preparation as well, not only for the moms, but also for the partners. Because the dad isn't experiencing the pregnancy and he might not know how to give the support or what to do when she's experiencing those things, or what to do when the baby cries. So it's there not only to assist the mom, but also with the dads as well. And it kind of includes the entire family in that. So antenatal classes is very beneficial. For moms that can go. There are so many classes throughout Johannesburg and Cape Town, and they just need to inquire from their local clinic, and they'll be directed to somebody that's close by.
So is that something that you do as well, the classes?
Yes.
Okay.
I don't do it myself because I don't have the time, unfortunately, but I have somebody that does my antenatal classes for me.
Okay, cool. Just checking. So we brushed through the drugs part, and drugs, not just like the drugs that you shouldn't be taking, but also like over the counter and prescription stuff. Only recently I realized that like adults have ADHD as well. But it sounds like the silliest thing. But there might be, and the reason I'm saying this now, you might have someone that's going through pregnancy that is on anti-anxiety or anxiety medication and stuff like that. How does that work through pregnancy then? Like, do they stop taking those, that medication? Because I'm just thinking that might actually make it worse. I don't know. How do they, have you come across that scenario before?
Yes. So there is the ADHD that you get, and a lot of people say, it's postnatal depression or it's prenatal depression. And I think we just classify it as one thing, but it's really not. It's maternal mental health disorders, or it's related to your postnatal depression, and then you get your perinatal mood and anxiety disorders as well. You can get your panic disorders that's in there. You get your postnatal, bipolar could be also linked to that. There's so many mental health issues that a mom could be experiencing, and we just sometimes classify it as one because we know, that's what we know. And I was at a talk the other day, and it's very recent that it's come to me. After all this time, I learn something every day, that we should also be screening specifically for mental health disorders. And they mentioned that it doesn't have to be done by a psychologist. It doesn't have to be done by a psychiatrist. You can use the Edinburgh Postnatal Depression Score, which is readily available on Google. And that's where you see the moms that might need assistance or not. And there's clients that, if we miss the diagnosis, then those moms are the moms that are not getting treatment, and they would be needing that. So it's all healthcare professionals should be firstly assessing for mental health disorders, or where we can provide assistance to assist with anxiety, because the anxiety is what continues throughout the pregnancy, and that's where it could cause the postnatal depression. And if postnatal depression is left unattended, that could cause postnatal psychosis, and it's a ricochet of all these things which should have been dealt with in the first place. And you know, diabetes and high blood pressure, you test for it on your, when they come in, we're looking at your sugar levels and we're checking your urine, but we're not assessing the mental wellness of our clients, which is so important. So with anxiety medication, if they're on anxiety medication, they should not stop the anxiety medication, because it can get out of control and it can get worse. They should generally speak to their providers about it. We can refer them to the psychiatrist or the obstetricians, who can then change or alter it and look at the safety aspects for baby, but never ever stop it. And the same with postnatally, if they are not feeling okay, because there's postnatal depression is only there for up to 6 weeks, right? In postnatal, the baby blues, for example, is just there for your 6 weeks. But postnatal depression could linger much longer than that, up to a year. And some people are only diagnosed, if they're still breastfeeding, they're only diagnosed with postnatal depression a year after, which you would think it can't be, she's just depressed, but it was missed all along. And that is where, you know, you come on and say, this is still postnatal depression, which wasn't treated from the get-go. And for pregnancy and breastfeeding, there is treatment that can be given. We just need to assess if it's safe for baby and mom. And if they were taking something that's not safe, then they need to be changed into something that is pregnancy safe. I was looking at one of the talks, they mentioned that there's an intravenous medication. It's given over 60 hours in hospital. It's something quite new. I think it's called Zoloft, where it's the moms are kept in hospital, or it's Xyleso, I think it's an intravenous, the psychiatrist would know best about that, but it's an intravenous infusion. It's given in hospital over 60 hours, and that is absolutely safe for both baby and mom, which is, it's something new on the market. So we are evolving every day, and there's lots of safe medication that's coming out every day, and we need to get the mental awareness out there so that moms that need assistance can come forth, and we are able to assist them without the stigma of the community and the family. And once we're there, I think that we'll have emotionally and happier, you know, parents of South Africa, or parents in our community, because pregnancy and birth can be overwhelming. And exactly like you said, it changes your body. You know, you could develop thyroid problems, diabetes in the pregnancy, high blood pressure in the pregnancy. But those hormones can also affect you mentally. And if it's left out of control, I was reading an article that said there are more postnatal depression, there's more cases of postnatal depression than that of breast cancer. So it's out there. 20% of the moms can get postnatal depression, and that's quite a lot. And we need to assist with that.
Yeah. Sorry, I was going to say, that's exactly what Sally said, you know, because it was, you know, it was new for me as well. It's like, I thought, you know, it's just a few weeks and then it's done. And she said, no, but it could linger for exactly what you said now, you know, up to a year. And I love how you said, you know, the whole mental health aspects to it, because, yeah, I mean, I don't think anyone screens for that, you know, and you know, like lots of those things, I mean, it's your own like thoughts around it. Again, we come back to that individual approach, you know, but how I don't know, maybe your birth was like traumatic, or and stuff like that, and now you're putting yourself through that. I mean, that must be quite difficult. Um, but I do want to ask with the anxiety one as well. And again, obviously we joked about the Coke one, or but with anxiety meds though, would that, and again, this is subjective, and you don't have to answer if you don't want to, but uh, I can't help but think that maybe that passes on to baby as well. Then I mean, like how does, because whatever you're putting as as the person carrying the baby, obviously transmits in some way. So, any thoughts around that?
Yes, there are some anxiety medication, and well, anxiety medication or all medication does cross the placental barrier. So it does go onto the pass through the placental barrier, and it does pass on to baby as well. And sometimes the mom's taking things that are too strong, that's not recommended in pregnancy, and our babies need oxygen therapy after birth or need even resuscitation because they are so drowsy and sleepy from that medication at the time of birth. And that's why it's so important that they do change over. And then you look at, so should I take my anxiety medication or shouldn't I? So, what would be best for me? And with anxiety and depression that's not treated, it could still lead to low birth weight babies. They are doing research and seeing that those babies could grow up and be ADHD. It does affect their learning ability as well. So those are ongoing studies that's currently being done for moms who've had anxiety or depression in their pregnancy and who did not treat their anxiety and depression. So you would want to get treatment. Most importantly, you want to get treatment that is safe. A lot of the times we'd really assess if it's needed or not, because moms could say, I'm anxious, and they're panicking, but it's not a panic attack and it's not anxiety disorders, which they're taking sleeping medication for or anti-anxiety medication. And it's not really diagnosed that they are, but they're just taking it because they want to feel calm for that specific moment. And 100% right, Oliver, it does pass on to the baby. So it's so important that it's prescribed medication. Those babies are then, it's an exclusion criteria for midwives to birth babies, that if the moms are on anti-anxiety and antipsychotic medication, because those babies need to be birthed in a hospital where there is ICU facilities in the event that those babies are coming out sleepy and drowsy and need reversal drugs to counteract that. They have that in place. So
Okay.
when we look at our low risk, high risk moms, those moms are flagged as a high risk for midwifery births.
Hmm. Okay. Thanks. Thanks very much for clarifying that, Ruwaida. I mean, so I think yeah, in my mind, I mean, I just couldn't, because that's the one thing. And again, I would love to see that research, because that must be pretty amazing, when it does come out. Because the other one that I find is that there's a lot more, and again, it might be just my perspective of my world, but autoimmune, Hashimoto's, all of that stuff. We spoke about changing in body chemistry and all of those things. But the trends that I find in the last few years is definitely like ADHD, anxiety, but autoimmune. I mean, like, I didn't know what a rheumatologist is like until probably 6 months ago. But a rheumatologist actually specializes in autoimmune disease. I mean, I didn't know that, but that is, yeah, that's a real thing. And so I think for anyone listening to this, I mean, and if you're going through pregnancy, if you're considering pregnancy, or even if you've been through a pregnancy, I think about all of these things, because I think sometimes, you don't put the dots together, but it could be related, and you probably, not just during that pregnancy, you probably have to, look at that and say, maybe this has relevance or not. I love this conversation, but in the times that we're living in, I can't help but ask, COVID. I mean, like, how did that affect your, like how you dealt with clients and stuff like that over the last 2.5 years now?
Yeah. So, but let me tell you about the mental aspects that and what's happened with COVID. In 2020, there was increased anxiety. People were frantic about COVID. The hospitals had almost closed down a lot of the methods and the ways clients were being taken in, where moms had to birth alone in a hospital with no support. Dads were left out, the families were not involved. So difficult for the nurses to monitor clients because of being in the hazmat suits completely. So a lot of the clients approached, they came through the midwife route where we could um, monitor the moms and the dads in a family unit. A lot of the home births had actually increased during the COVID time because moms didn't want to feel isolated, and we could incorporate that into our care. Because we do one-on-one nursing or one-on-one cases. So we're not looking after 5 clients in a hospital, but we only solely focusing on that one specific client. If our moms were positive during COVID and they were symptomatic, we had to unfortunately refer them to a hospital. And those moms had to birth in isolation, where the midwife or the nurse at the hospitals were only coming in to do the checks and then leaving them again. So we incorporate a lot of our care involves doulas. Our doulas, our support persons, which massages the moms, walks with the mom, assists her to breathe. And at COVID time, there was none of that because of the limited amount that was allowed in hospital environment, which was extremely difficult for clients. The anxiety levels went up. We've seen a lot of moms in depression and difficulty in coping, not only antenatally, but also after birth. Difficulty in coping with their babies, difficulty not knowing what to do. I'm positive. How do I breastfeed my baby? Or do I give my baby bottle? So a lot of uncertainty with that as well. So anxiety levels were through the roof. It didn't change the way I practice, I must say. I still went in. If my moms were positive, Warful hazmat suit stayed with them, was able to massage them and give them that because that was what they needed. If I needed to do a home visit, dress up, go through and go and see them and ensure that I'm protected as much as they were. During that time, I initiated home COVID testing, so bought a few kits out, went house to house to try and limit the COVID exposure and did rapid testing to ensure that they were also, they knew what was happening, and if they were positive, they're able to remain in isolation. And I must have did about 10 COVID tests on myself as well, just to ensure that I'm okay and I don't, infect anyone and they positive. So there was a lot of anxiety around it, but we managed it and we came through it. And the moms still, we were able to give them that beautiful experience and were able to give them a lot of psychological support. We did a lot of online Zooming as well to ensure that we could check in with them on a daily basis to make sure that they were okay if they were unable to come to us or we were unable to get there. With the moms moving out of the hospital, they moved a lot into the midwifery units. So with that, we were able to provide the service that was needed, and obviously with backup, with hospital backup, and we had quite good success with that.
That's amazing. I mean, the level of respect is like sky high from my perspective, hey, in terms of how you manage that. That's and I think that's the thing that COVID taught us is like we don't know too much in terms of. I mean, the whole world was just like shaken, but it was a healthcare practitioners, like yourself, that went through the front lines and just have to do what you do and try to keep it as best as we can. Because, like you said, I mean, it's such a high touch, and, you painted the best case scenario for us. And then you're saying, now we have to do it with the hazmat suits. And, obviously that can't be good. And I just wonder, like, those babies born during that time, the level of anxiety is high with the mom, with the rest of people around them, and the one thing I did learn, and even from our own children, is like, like how sensitive they are, to things around them. If you're afraid, they almost pick that up. Like if you go into a new place, they pick that up. They all they're anxious as you're walking in. But if they pick up lots of those cues, and I'm a firm believer, like babies do that. They can sense that, and I think that's where that drug discussion comes in, or anything, what you put in your body, whether it's smoking. I think it definitely comes up somewhere. But
Yeah.
thanks very much for doing that. Sure, that must be. I think for your family as well. I think that's the other thing is that you're going out to the patients, but you also your family then is probably at risk.
Yeah, yeah. So they had to we had a routine with they knew I'm going out, would come because it's not easy for them. The last thing you want to do is also infect them if you're positive. So work with backup plans, come in, take down everything, make sure you shower before you get into the house. Don't touch anyone or breathe or do anything, but isolate yourself for a bit, get cleaned up, and then start with doing what you needed to do at home. But one of the things we realized as healthcare providers is that if we're not there for the client, they have no one. They were totally in isolation. So we needed to be their friends, and we needed to be their family at the same time that we needed to be the healthcare providers. And we got together and we did it, and we loved it. And the sad thing is, babies were born, and they didn't see anyone else but their parents. So the babies that were born during that time, they're very attached to their parents. There is a lot of fear with them. A lot of them don't, they're still afraid to be put down or to see others. One of the babies, we were just chatting, and one of my colleagues said, the baby doesn't know how to smile because the child had always seen people with masks. So even the parents were masked up all the time, that the baby had to learn how to smile. So, we don't see one another's faces anymore, which has definitely had a negative impact on our social well-being.
Yeah, again, I mean, there must be I mean, like, I would love to see that research when that comes out. But what you're just saying is, I mean, it's what I think. And I was speaking to someone where her little boy was born during that time. I think they've actually fell pregnant straight off, during that time. But she was just saying, like, so things that you would think is normal, like play dates, like obviously 1, 2 years old, but that wasn't possible. Like, like people stayed in their own homes, and that has like a social dynamic to it. Even now, like, but when you said, how clingy the babies are, that's what I thought of. Is that's exactly how she said it was as well. Like the baby's a lot more clingier to her. It's a little boy now, but yeah, around that, which I thought is interesting. And then, yeah, like you said, the masks. I think people were definitely, healthcare practitioners were coming out in the mask, you could still see the face or the mouth. And I thought that was
Yeah.
cool, but that didn't seem to take off too much. I didn't see many many of those. I do want to close off now. I mean, I love this discussion. I mean, your passion and your knowledge, is clear, for anyone to hear and see. But we try to do the best we can with the topic. But is there anything around being a midwife or antenatal care that you thought I should have asked you that I didn't?
I think you've covered it quite a bit. What I'd like to add in terms of mental well-being, just focusing on exactly what you do and you discuss, Oliver, is there's a lot of trigger aspects that moms will note. So if you're a mom and you're unsure about what you're feeling and you feel anxious, or you're constantly focusing on the well-being of, on, am I going to be okay? Is anything going to happen to me? And those are the thoughts that run through the mom's minds. And or you becoming anxious, or you becoming depressed quite often, or you screaming at your husband and the family, and you notice that you're extremely angry all the time, and you're not getting these moments that you actually settle, please speak to your care provider about it, because there could be triggering aspects there. And, you know, if there is any mental anxiety disorders, there's always something that we can do about it. And if you don't want to go on to medication, there's also a lot of homeopathic medication or natural remedies that can be utilized. See a psychologist, debrief with a social worker or psychologist. And sometimes just talking about it can put things into perspective, that everything that you're thinking about and you're so overwhelmed with, there's definitely something that can be done, and we are here to assist you as healthcare workers and providers, and that's what we're here for. So if ever you're overwhelmed, reach out to your professional, your care provider, so that they're able to provide that assistance to you.
I love that. I love how you brought in the psychological aspects to it as well. I mean, I think, you know, that's the thing that we forget to mention. And I think obviously the world's changed in the last few years. Even before COVID, I think there was a shift towards mental wellness and knowing more about what's going on with people. But I love that. We'll include all of your details in the show notes. I love your website. I didn't say that so far, but it's miraclebirths.co.za. You know, as you go in, you can kind of, you know, feel that warmth as well. You know, I think the colors, and so whoever did that, you know, good job, because you can kind of feel that. And I love what you do. And hopefully, I mean, it's been a useful, you know, it's been a useful episode, you know, to anyone that doesn't know about this. And I think what I would have wanted to get out of it is almost opening up the possibility that there isn't just one way. You know, once, you know, like you just, you know, you are in the pregnancy, I think the whole midwife aspect, I think there could be a lot more done, I think, from a body maybe perspective, to make it more I wouldn't say accessible, but more informed, you know. And I just think, you know, generations back, I mean, my gran had 9 kids, but, you know, it was like, as you said, you know, the elder women in the community that did this, you know, they didn't have doctors and stuff like that they went to, and all of the kids seemed to be fine. So yeah, subjective. But thanks again for your time. Really, really appreciate it.
Thank you, Oliver. Thank you so much for having something like that, to getting it across to the community so that they can understand as well that there are different aspects to prenatal and postnatal care, and we are here. I really appreciate the show for helping to reach out to the community as well.
No, you're so welcome. Thanks again. Hey, everyone. Thanks for listening. As always, stay tuned and we'll speak to you in the next episode.